So complications of cataract surgery, let us divide it as peroperatively, that is during the operation, we will call it operative complications, right? Then early post-op or acute post-op, and the third type we will learn as chronic post-op complications. So what I am discussing today here is one important ones with the chances of being asked in the exam, right? Otherwise, the usual common findings post-operatively like mild corneal edema which subsides and all is very common. But what are the major complications I am talking about? Let's talk about that. So first, operative, which needs mention as a very serious complication, is your posterior capsular tear. Right? It is posterior capsular tear. Now, when there is a posterior capsular tear during the surgery, of course, this is something every surgeon dreads of. So once this has happened, it can either be with the vitreous loss or it may be that the vitreous phase is not disturbed yet. Okay, so it could be two ways, either without any vitreous loss. Now, this is of course a better option. We will have lesser sequelae and complications, but if it is with vitreous loss, naturally we have invited a lot of more problems. And what can be the problems if there is with the vitreous loss? We have discussed this, that any vitreous loss can cause a pull also in the retina, which can lead to retinal detachment. Then there can be increased chances of cystoid macular edema, right? So we'll note it down a few of them. Like first is your CME, which is cystoid macular edema. Or it could be retinal detachment, which can be after a vitreous loss. Then, of course, it can be a cause of endophthalmitis. It can be a cause of glaucoma. And I don't want to give you a long list to complicate, but there can be many other problems. So that was about your PC tear, and according to what is coming up, we have to manage it. And of course, we are not able to put the lens in the capsular bag anymore, and we have to find some alternatives. This has already been discussed with you. Right, then we talk about, and of course, can you also think of lens drops? If the lens is actually dropping into the vitreous, again a dreaded sequelae. We come to the next important complication is your suprachoroidal hemorrhage. So during surgery, to get suprachoroidal means the space between sclera and choroid. So suprachoroidal hemorrhage, if it is occurring, why will it occur first of all? Either it is occurring during anesthesia when you are giving your perivulvar, retrovulvar, you have punctured it, right? So either during anesthesia or sometimes a gross variation in the intraocular pressures. Okay, a wide variation, or you can say fluctuations of sudden changes of intraocular, we should say sudden changes. Either it is due to anesthesia or sudden changes of intraocular pressure. So whatever may be the cause, now what has happened is there is a hemorrhage, right? Now this hemorrhage, what can this lead to is very, very important to understand that if it becomes a very severe hemorrhage, then it can even cause, because your already incision is open, extrusion of the intraocular contents. And when that happens, that is what is called expulsive hemorrhage. This one is your exam question, okay? So please understand, it's not, expulsive hemorrhage is nothing but suprachoroidal hemorrhage. And if it is severe, the intraocular contents are expelled out. And this intraocular content, the expulsion is what is called, therefore this is called expulsive hemorrhage, okay? So when you say expulsive hemorrhage, how will I know, okay, this is happening? You will see that naturally there will be progressive shallowing of the anterior chamber. The pressure is rising, and then what will happen? In expulsion, iris prolapse, then vitreous is also coming out, vitreous prolapse, and loss of red reflex. Okay, so when we say expulsive hemorrhage, of course, we will not be able to save the eye if we don't stop there, because it can lead to iris prolapse, then vitreous prolapse finally, and vitreous prolapse, keep writing please, is finally leading to your loss of red reflex. That means now the retina has also been affected. Now the question they have asked you is, make a cue here please, which are the arteries which are being which are leaking or bleeding Or hemorrhage is from which artery actually? So puncture of which arteries? Where bleeding is happening from which arteries? It is short posterior ciliary arteries which are supplying the choroid. So we will learn these are short posterior ciliary arteries which are supplying the choroid. Because of the leakage of these, why I am saying leakage, I'm so sorry. Because of the bleeding from these arteries, there is a suprachoroidal hemorrhage or expulsive. So this is an important cue. What should I do if it has started? It has still not gone into a stage of expulsion, but I know it is a suprachoroidal hemorrhage. Immediately stop the surgery and resuture everything quickly. Okay? We don't want to drain the blood during this acute phase. We are going to wait for 7 days. If it does not resolve, then only we go for drainage. Note it down. Okay? So sclerostomy is never done immediately. We wait for it to absorb, and after the acute stage, after a week, if needed, we can go for sclerostomy. But immediately what we do, we will write down resuture and immediately terminate the surgery. And of course, after resuturing, we may have to also manage, stop the surgery and resuture it. As of now is the main and immediate step that has to be taken. Of course, for the glaucoma management and systemic and topical steroids postoperatively may have to be continued. But sclerostomy, so main point, let's note down that sclerostomy for the drainage of hemorrhage is only done when it is after 7 days and it has not reabsorbed. So we will learn, don't do sclerostomy immediately. This is the important takeaway here. Right? Okay, so that was suprachoroidal hemorrhage. We come to the third intraoperative. We already know about this, UGH syndrome. We have just talked about it is mainly a complication of ACIOL. I'll not repeat again. So it is uveitis, glaucoma and hyphema. Okay, what next I can get during, I'm again telling you, I'm picking up the important and serious ones, the ones Vishni will a little more mention. So that is your Descemet's membrane detachment. Okay, so the next that can happen during operative is DM detachment. When there is a Descemet's membrane detachment, we have to go for descematopexy. How do you do that? Just inject air. Due to the pressure, the Descemet's membrane reattaches. Okay, that is called descematopexy. This is done by injection of air. Okay, in the anterior chamber. So this was about some important ones. These are operative complications. Now we talk about next heading is acute postoperative. Talking about acute postoperative complications. Acute postoperative complications, one most important post-op day 1, and what I am getting is a shallow anterior chamber. What can be the causes of shallow AC? If I am getting it in 1 or 2 days, what is the cause? So let's think. Shallow AC, either the wound is leaking, so aqueous is coming out. So one cause could be leak. Okay, one cause could be leak. And how do you check it is a leak or not leak? We go for Seidel test. Everybody should know what is Seidel test. This is important. What do you do here? You are putting the fluorescein, and if there is a leak, the area from where the leak is happening, you will see that there is dilution of the fluorescein. That is what is called Seidel test, where you are checking the dilution of the fluorescein due to the leakage of the aqueous. Correct? Okay, that is one. Second, we have to know what can be the next cause of shallow AC is very, very important, pupillary block glaucoma. Right? So you all know about pupillary block glaucoma. Any block out here means aqueous is being collected in the, aqueous is collected here. And if the aqueous is collected in the posterior chamber, it is not draining, it is pushing the iris forward. This is what is called iris bombay. And what happens? It touches the cornea, leading to pupillary block glaucoma by blocking the drainage. So that could be one cause. Post-operatively, there could be a pupil block due to any of the reasons which is causing shallow. So what I am going to get here is a shallow anterior chamber, number 1. What could be the second? Second, very important, we are going to learn the details in glaucoma chapter as well, is your malignant glaucoma. Write down please there, malignant. What is malignant glaucoma also known as? We call it ciliary block glaucoma, or we can call it your third term is aqueous misdirection syndrome. Aqueous misdirection syndrome. What is this aqueous misdirection syndrome? Where aqueous is being collected in the vitreous cavity. All of you draw with me. On your copy, how will you write? That aqueous normally should be going anteriorly. Instead of going anteriorly, it is being collected in the vitreous cavity. So naturally, common sense, it is going to, if too much of aqueous here means pressure is more, it is going to push the lens iris diaphragm anteriorly, and that is going to lead to very shallow anterior chamber post-operatively. So that is another cause of shallow AC, right? Okay, what do you do there to manage? We'll learn in detail, but if you want to know, generally majority of the patients will respond to atropine. So atropine is just expanding the ciliary ring and breaking that block so that the aqueous can flow anteriorly. So we'll talk about the details in glaucoma chapter as well. Then we talk about your, so these can be the causes of what? Yeah, one more. So this is what a Seidel test. The Seidel test is checking for the dilution of the fluorescein to check if there is any leakage or not. Okay. So once we know this, and yeah, so this what do you see here is, you're looking at hyphema. So these are the causes, and one more cause you can write down is your ciliocoroidal detachment. Ciliocoroidal or choroidal detachment. Okay, this could also be a cause of, naturally, this detachment is happening and this is a cause of shallow anterior chamber. So just know these are the causes of shallow anterior chamber. We come to the next very important post-op, acute post-op complication, which we are going to learn in detail, is your endophthalmitis. So the next important one is endophthalmitis. One was shallow anterior chamber. The second one we are learning is endophthalmitis. I think we have discussed this so many times that it's an inflammation of the innermost coat of the eyeball. Panophthalmitis means all the three layers are involved. Endophthalmitis means the inner coat. Now, what is the latest definition? I want you to write it with me. It says it is purulent inflammation. This is in your latest edition of Kansky. So, purulent inflammation of intraocular fluids. Okay, it is purulent inflammation of intraocular fluids. We are talking about vitreous and aqueous here. Usually due to infection. This is actually the definition now for endophthalmitis. And of course, when we are talking post-operatively, it is happening majority of the time it is due to infection. Now, which infection is your exam question? Which infection? So, most common etiological agent causing acute onset, we all know, is staph epidermidis. Okay, it is staph epidermidis. And if you talk about the most common that can happen post-traumatic, right? Post-traumatic, then after trauma, if there is an endophthalmitis, this time it is bacillus cereus. So they haven't asked you this. This is mainly important and this has been an exam question. Anyway, whatever may be the etiological agent, we have to understand a very important thing, that a hallmark feature of endophthalmitis is progressive vitritis. One important point before I talk the details. It is progressive vitritis. So how will this patient present post-operatively? Of course, he's visible. There's worsening of pain, right? Okay, so how will the patient present? The clinical feature that we will note down is, number one, worsening of vision instead of improving. So this is such a big panic for the patient. After operation, there is worsening of vision, number one. And second, all the 5 signs of inflammation like redness, pain, right? Photophobia, right? We have learned this in conjunctiva and cornea, photophobia, blepharospasm, discharge, right? All these things, these signs are going to rapidly progress or increase. So this also worsens, rapid worsening or rapid progression of these symptoms. So when I examine, so I am also, when we test, okay, what is this happening to the patient? So the nightmare has become real. So we are going to check on it. Do you know, this is also one of the reasons we never operate on two eyes together now. It's a rule, because years back, this has happened that a single patient has got operated both the eyes simultaneously in the same sitting, and when there was an infection, it affected both eyes and the patient is totally blind. So to just avoid such a dreaded incident or tragedy, now it is a rule you never operate two eyes together. And if I'm doing a phaco, I have to still keep a minimum of interval of 2 weeks before I go to the next eye. Okay. Yeah. So what do you see on examination in these patients? So on examination, what I see here is your, let us write like this. There is of course diminution, progressive visual diminution of vision, and there is lid swelling, right? Chemosis, conjunctival swelling, this is chemosis. Then we will mark corneal edema, correct? There can be hypopyon. You all know what is hypopyon? Pus cell in the anterior chamber is hypopyon. Then all the signs of anterior uveitis may be present. Of course, I told you about vitritis being the hallmark. So you see a lot of inflammatory cells and exudates in the vitreous. And because of this, the media is so hazy. Very important finding. No fundal glow or lesser fundus. Fundus glow is absent. Fundal glow not seen, absent in severe and late cases, right? And of course, there will also be in the retina. If you see, there will be periphlebitis, retinal periphlebitis. What is periphlebitis? Inflammation of the veins. So we are seeing all these things in this patient. So once I know, okay, this is a case of endophthalmitis, now comes the point how to treat it, right? So let us understand how to treat it. Now this, according to the latest study, which is your EVS study, is endophthalmitis vitrectomy study, okay? So according to EVS study, so EVS stands for endophthalmitis vitrectomy study. If this patient, we see first check the vision of the patient. Now, if the vision is not even hand movement is also not there. So if no hand movement, the vision is that less, only PL, only perception of light, then you have to go for pars plana vitrectomy. So anything less than hand movement is pars plana vitrectomy. But if this patient has hand movement or above, either hand movement is there or a better vision is there, then of course we have to treat it with conservatively. Okay, got it all of you? So why do you call it pars plana vitrectomy? I hope you all are clear, because we always enter the vitreous cavity through pars plana, right? So because we are entering through, how do I know I'm at pars plana? Around 3.5 millimeter from the limbus. So if this is the limbus, I am 3.5 millimeters from the 3 to 3.5, both we are at pars plana only, 3.5 or sometimes a little more than that, and you enter through this, then you are going through the pars plana. Okay, so we generally go through pars plana. We don't want to damage the zonules in the lens. This is why we call it pars plana vitrectomy. Acha, coming to this conservative, this is exam question, guys. What is the treatment of choice of endophthalmitis? So if it is even a general question or if vision is given, whatever, then we have to answer. Of course, you have to answer according to this if vision is given. Okay? Hand movement hai ya nahi? Then you will, and if it is so, then you answer intravitreal antibiotic injections. So this is very important, that what is effective is intravitreal antibiotic injections. Now, what are the antibiotics I give intravitreally? We will learn. This is ceftazidime and vancomycin. Ceftazidime for gram negative, vancomycin gram positive. And you may also give small doses of dexamethasone to control inflammation. right? Okay. Now suppose, now there's one more question for you all here. Which are the antibiotics which are contraindicated intravitreally? I am not allowed to give an intravitreally are gentamicin and amikacin. It is gentamicin and amikacin. Why? It is toxic to macula. It is maculotoxic. We will avoid this. Right? Okay. And then there's another question about, suppose the etiology of endophthalmitis, it's a late onset and it is fungal. Right? If it is fungal, then what will you give? Which antifungal is allowed intravitreally is your exam question. Allowed intravitreally and you can give, we will now answer amphotericin B. This was the answer of your question. Please make a cue here as well. It is amphotericin B. Okay? And what is the another one which is allowed is a new drug called voriconazole. Okay? It is voriconazole. Right. And of course, I am not only giving this intravitreal, I may give some systemic antibiotics as well. Systemic antibiotics, mainly if I am choosing, I should choose quinolones because the ocular penetration of quinolones is much better. Okay. Now, if you talk about topical and subconjunctival, not much of use. But yes, you want to treat associated uveitis, you can give cycloplegics, and steroids, of course, can be given under these antibiotic covers. Right? So, we have to management of the associated uveitis, anti-uveitis that has happened by giving your cycloplegics and topical steroids under the cover. Right? So, that was about endophthalmitis. It's a very important topic. You should know in and out about it. Okay, so these were the acute post-op, the most important ones discussed. Now we will come to chronic post-op. So next heading is chronic post-op. Let us continue with endophthalmitis only. What is the cause of a late onset endophthalmitis? This is also your exam question. So first again I will talk about endophthalmitis, but this time it is late onset. When does it start? That's variable. Okay, from weeks to months, but commonest is around 9 months, after 9 months. Easy to learn also, right? So after 9 months or so, average if we take, it is presenting, and of course we know, Q lagao, the cause is Propionibacterium acne. So Propionibacterium acne. Correct? Okay, and sometimes it can be there in the capsular bag, sitting there and causing infection later, endophthalmitis. That is why you can call it saccular endophthalmitis. If it is in the bag, so we can call it saccular endophthalmitis. Generally, it is in the bag only. This is the method of its infection. Okay, so how will, once we know this, how will it present? Now, you've just learned the acute, it is easier here. This time, pain is not there. It's generally a painless condition. Important, right? Different. But yes, there is, though not very rapid, but mildly progressive diminution of vision. Mild progressive diminution of vision, decreased visual acuity, or you can say diminution of vision. And when I'm looking, I can even see, as you know, hallmark is vitritis. So again, I see mild vitritis. So anyway, this is on examination finding. Patient is mainly talking about diminution of vision, which is mild but progressive, and there is no pain. And when I examine this patient, what I am seeing is low grade, just write like this, low grade anterior uveitis, all the signs of low grade anterior uveitis, okay, and mild vitritis. This way we will learn. So we won't write mild vitritis here. So we will write it on examination. Okay? So once we know this is the presentation and we doubt, okay, this is this bacteria, we can go for what is the treatment part. Treatment, you have to start with, of course, intravitreal antibiotics only, right? So intravitreal, what is preferred antibiotic here will be vancomycin, right? This is an anaerobic bacteria, okay? So you can even use aqueous and vitreous for the culture to confirm it. Okay, when you do the culture, you will confirm, okay, it is Propionibacterium acne, and start with intravitreal vancomycin. And of course, we also give quinolones, preferably moxifloxacin. Okay, so we start with systemic quinolones as well. Quinolones we will go for. Sometimes I feel speaking, I start pronouncing little differently, huh? Anyway, so systemic quinolones. And mainly what is preferred is your moxifloxacin. Okay? Chalo. And for the uveitis part, of course, this you have to manage the uveitis. Management of uveitis as per discussed. That was about your slow. And what was the other cause of slow onset? I just mentioned it could be fungal also. So this is again your exam question. Which fungus most commonly causes endophthalmitis? Your answer will be Candida albicans. Okay, learn with me. What about most common fungus causing orbital cellulitis? Now you will answer mucormycosis. You will answer mucormycosis. Okay? And which is the most common fungus causing keratitis? Tell me. This I think everybody will answer me. Mucormycosis anyway is very important, right? During the corona time, everybody knows the injudicious use of all these steroids led to a lot of disturbance in the immune system, and so many people lost their eyes due to mucormycosis. Anyway, then most common fungus, we'll discuss mucormycosis in the orbit. So most common fungus causing keratitis, I think everybody knows, Aspergillus fumigatus. It is fumigatus. Correct? Anything else left? Yeah, what about the lids? For lids, again it is Candida albicans. So now I think you are thorough with the causes of fungal infection in the different parts of eye. Okay, now we talk about next, what is the complication you have to learn is very, very important Q, and it is most common long-term complication of cataract surgery. What should you answer? Your answer will be posterior capsular opacification. We also call it after cataract, or we also call it secondary cataract. So there are three names for this condition. Now this needs a little detail. It's an important topic. Very simple topic though. So what is after cataract? Your patient is very happy after the cataract surgery that you have done, you have operated. He goes home. After a few months, he's back again. And I'm again seeing blurred. What happened? Have you got cataract again? That's not possible. You have removed the lens. Huh? So what is happening now? The posterior capsule on which you have put the lens, that is getting opaque. Right? This is what is called after cataract, secondary cataract, or posterior capsular opacification. Okay, now what further we have to know? Morphologically, this is divided into three types. Either this opacity is just a diffuse opacity like this, or it could be circular opacities like this. What are these known as? We call them Alschnick pearls, right? We call them Alschnick pearls. Or it could be just a fibrotic ring at the periphery, and this is what is called Sommering ring. Soemmering. Okay, Sommering ring. We'll just see the slide. Let's finish this. So now what is happening? Definitely, if this is morphologically, this is the thing, and if you look at here, you have already put the lens somewhere here. No? The lens has been implanted like this over it. So this is your lens. I'm just making it a little darker, so I'm putting it like this. Or should I? Wait. Let's use a better color. Chalo. So ये आपका lens है. This is the lens implanted, and we have put it like. Right? Okay. So did you realize something here, that which one of these are going to cause problem are diffuse type? Again, why it is happening? What is diffuse type of opacity? It is again fibrous metaplasia, okay, of the posterior capsule. It is due to, write down, fibrous metaplasia of posterior capsule. Okay, of the epithelial cells, I mean to say. So it is a fibrous metaplasia. This is also called diffuse, or you can say fibrosis type PCO. So fibrosis type is looking like a diffuse thing, and this is nothing but fibrous metaplasia of epithelial cells. What are Elschnig pearls? They are migrated epithelial cells. So Elschnig pearls are nothing but migrated epithelial, anterior epithelial cells. Isn't it? We have anterior only anyway. And then Sommering ring, again it's a peripheral, the proliferation of whatever residual cells is forming a ring like this. Okay, so this is proliferation of residual cells. Nobody will add this much detail, just know the three names and just understand that what is happening in fibrosis type and Elschnig pearl is it will cause diminution of vision, it will cause blurring. So the clinical feature first is blurring of vision, and later it will lead to diminution of vision, blurring and then diminution of vision. So purpose of the whole surgery is gone if there is a vision problem. So what to do about it? Solution is very simple, and the solution is that cut at the center to clear the visual axis. I can't cut the whole thing, it is supporting the lens, but I can cut at the center so that the visual axis is clear and the patient can see clearly. So this is what am I cutting? Posterior capsule. So we call it posterior capsulotomy. So earlier it was done surgically. Again a hassle of giving the anesthesia, opening the eye, going behind the lens. We used to just put a nick here and it would open. But now we don't need to do that as well. It's an OPD procedure. So what is the treatment of choice? Exam question. OPD procedure kaise karte ho? We go for through laser. So we are doing laser posterior capsulotomy. This is the treatment of choice. So which laser? Nd:YAG. So it is Nd:YAG laser posterior capsulotomy. I am reminded of another one question here. Note it down. They have asked you that which IOL will have a least chance of getting a posterior capsular opacification. So which IOL? You will answer. Again you will answer here. Hydrophobic acrylic. Okay, this is your again exam question. Hydrophobic acrylic has got a least chance of posterior capsular opacification, right? So that was about your after cataract or secondary cataract. Okay, a few more complications which can be a possibility as a long term, very important, needs mention is cystoid macular edema. Right? So any cystoid, cystoid, why do you call it cystoid? There are spaces, cystoid spaces filled with fluid. It is a reversible type of macular edema. So cystoid macular edema, that means there must be something opposite where there are no cystoid spaces. Yes, that is called amorphous. And amorphous becomes a permanent damage. So they will not ask you in that detail, but you should know what is CME. So any CME after cataract surgery, what do you call it? Irwin-Gass syndrome. Right? This is important. Irwin-Gass syndrome is what syndrome? It is mainly because of, so what is happening here? There has to be, if there is any vitreous loss that is causing cystoid macular edema, that will also be leading to vitreous touch. Vitreous touch means it is touching the cornea, and when it is doing that, it is causing keratopathy. This is Irwin-Gass syndrome. Right? Yeah. So this would also be generally, it becomes, that means a complication of complicated surgery. When there's something like PC tear and vitreous loss has happened, then the chances of CME is high. Okay, what can be the other possibilities and other problems? What can happen is, the capsulotomy that you created in the anterior capsule when you have put the lens in the back, later what happens, even there is a contraction of fibrosis of that anterior capsule. So that is called anterior capsular contraction and fibrosis. Even this, just know it as a heading so that you know this is also an occurrence which can happen. That's it. And if this happens, even this can be cut with a laser only. Okay, that means this time I will cut and make a central opening in the anterior capsule. So again, I can manage it with Nd:YAG, anterior capsulotomy. Okay, so we can manage it with Nd:YAG laser. And of course, what needs a mention is displacement of IOLs. Instead of being in the center, if it is displaced up, we call it sunrise syndrome. If it is displaced down, we call it sunset syndrome. And of course, it can also displace laterally. So there can be the different types of IOL displacements. The IOL that you have put, displacement of IOLs is another important thing. Right? Okay. Then next we talk about, and of course, one more thing, CME, how do you treat? I'm going to take it in the retina chapter, but mainly you should know we go for topical NSAIDs and oral acetazolamide if you want to write it. So we've used C inhibitors, systemic C inhibitors and topical NSAIDs. So displacement of lens are done. Now another very interesting term. You know, sometimes IOLs, and we are talking about monofocal IOLs, not the multifocal, which can always be a risky affair because many people are not adjusting to multifocals. We just mentioned multifocal, which takes care of different distances, near vision, intermediate vision and long vision. Anyway, we are saying that you have put up monofocal, still the patient has some annoying disturbances, flash of light or some dark shadow. That is called dysphotopsia. Just know this, okay? I don't think they will ask you at your level, but just know dysphotopsias are nothing but some annoying visual symptoms due to monofocal IOLs. Okay, so they are annoying visual phenomenon. I find annoying to be a very negative word, but anyway, this is what it is here. You have to use this word. So it's an annoying visual phenomenon due to, write down, due to monofocal IOLs. Okay, done. And of course, another term I am going to tell you, interesting, but commonly this can also happen, and that is refractive surprise. So later on, when the patient is done with healing is happening and everything, you realize, oh my God, he needs residual refractive error is too much. Calculation of biometry and power has been faulty, right? That is called refractive surprise. So if there is a refractive surprise, means significant residual refractive error. So it is nothing but significant residual refractive error. So if there is a significant residual refractive error, how would you like to manage it? I can give specs. If he says, no, I don't, मैं चश्मा नहीं लगाना चाहता, okay, go for contact lens, right? Or what you can do, not a very easy thing, but IOL exchange is another option. Or sometimes put another IOL to create a correction. And this is what is called piggyback IOL. I just wanted you to know this term, right? Piggyback. So you have put the IOL in the sac, in the capsular bag. Now put in the ciliary sulcus. So these are called piggyback IOLs. Just one line information that you should know. Okay? Yeah. So this was about your different complications of cataract surgery. Right? Now next what we are going to talk about is congenital cataract. Okay, wait. What about the slides? Let's see the slide. Okay, you just wanted to show you this is what is suprachoroidal hemorrhage. Okay, this is the suprachoroidal hemorrhage. Right? Can you see this? An ultrasound B scan is showing the same. This is how it looks like. This is your Descemet's membrane detachment. And this is a case of endophthalmitis with hypopyon. Lot of redness in the eye. Corneal edema. These are the things which we can appreciate on this slide. This is the opacity, the PCO fibrosis type. Okay. So this is your posterior capsular opacification, which is fibrosis type or diffuse type. And this one, can you see these circular opacities? So these are your Elschnig pearls. Elschnig pearls. Again, if you look here, this is your Elschnig pearl. This is the IOL already implanted, and these are the Elschnig pearls. Look here, this is Sommering ring. Sommering ring. So Sommering ring is just a chance finding. The patient is not having any problem. The vision is absolutely fine because the fibrosis is all at the periphery. So here you can see the displacement of the lens, all of you. Displaced IOL. laterally, right? In this case, laterally. Here, this is sunrise. IOL is displaced above. Again above, sunrise. I can see the dialing holes which at the pupillary area. This would cause so much of annoying visual symptoms again with lot of problems here. This is your sunset syndrome where it is displaced downwards, right? Our next heading, therefore, please give the heading congenital cataract. Give the heading congenital cataract. I think we discussed this, that congenital cataract can either be developmental cataract or infantile. We call it infantile when it is within less than 1 year of age, right? So we are talking about mainly here embryonic and fetal nucleus. And when you're talking about developmental, we are saying more than 1 year of age is all developmental. That means this time which nucleus mainly involve which part? Infantile and adult. Correct? So, talking about why will a child develop a congenital cataract. So, what is the etiology? Now, I'm making things very simple for you. Whatever etiology you know about any congenital anomaly will fit in. So, first I think we all know about tortuous infections. Right? So, tortuous infections, T stands for toxoplasmosis. We all know this. Then rubella, cytomegalo, herpes and syphilis. So, any of these infections but in the first trimester can cause congenital cataract. What else we can think of? Any radiation exposure in first trimester? Right? What else? Teratogenic drugs in first trimester. Thalidomide is now not used at all, right? Okay, can we think of something else? Yes. We can think of some metabolic causes like metabolic causes. So one you talked about infective, you talked about radiation, drugs, and metabolic causes we have to know, we have discussed this also, galactosemia. We can talk about Fabry's disease. And thirdly, Lewis syndrome, right? So these are the metabolic causes we can think of. Then hepatic disorders like Wilson's disease, right? This is also discussed in acquired as well. So Wilson's disease. Then chromosomal disorders like Down syndrome. Chromosomal disorders like Down syndrome. Now, Down syndrome, what type of cataract we get? This has been your exam question. So, we will answer, this is blue dot cataract. Mainly, blue dot cataract or punctate cataract, we call it, is also a feature of Downs. Okay. Then what else? Of course, it can be just a congenital cataract, could be due to your genetic cause, right? So, congenital could be due to genetic cause. So, when you say genetic, that means there is a positive family history. And the inheritance, please learn with me, is autosomal dominant. Now, there's a question here that which genes are responsible for congenital cataract. So, the genes that are responsible have to be learned. I think I mentioned that when I was teaching you Lense proteins. One is your CRY genes. CRY genes is crystalline gamma. Right, stands for crystalline gamma. Second, you should know is connexins, CX. It stands for connexins. And third is your MIP, which stands for major intrinsic protein. Major intrinsic protein. So these are the genes which can be responsible. So if there is a positive family history, we don't need to think of anything else. It becomes a congenital genetic cause, right? So these are the causes, or it could also be a part of birth trauma. Lastly, okay. So all these causes that you've just enumerated, keep in mind, are all bilateral. So all these causes means, I mean to say, from 1 to 7 that you've noted are bilateral cases. Yani congenital unilateral cases are not that common, and they generally due to birth trauma or some cases of ROP. Not all, but some cases of retinopathy. We will talk about this in the retina chapter, retinopathy of prematurity. Right? So, where there can be both unilateral or bilateral, but these are the main cause of unilateral congenital cataract. So, once we know the etiology, we will talk about types of cataract. All the types are based, the names are given according to the morphological appearance. Right? So, whatever it looks like, we have named it. So, first is your blue dot cataract. Let us write it first. We will see the slide later. Blue dot cataract means common sense. When I look at the lens, I see some bluish dots on as a cataractous opacity. Blue dot cataract, as I also mentioned, is a feature of Down syndrome. Right? Now next we talk about, after this is after blue dot we talk about is cataracta purulenta. Cataracta purulenta. What does this means? Powdery appearance. Okay, so there's a powdery appearance of the opacities, becomes a purulenta. Now, even blue dot is including both nucleus. The changes are including both nucleus and cortex. And in purulenta also it is both nucleus and cortex which are affected. Okay, we all know the parts of the nucleus of the lens. We come to the third type of cataractous opacity, which is very important, is lamellar. We also call it zonular cataract. So what happens here, that at one time, suppose there was some environmental insult, so one lamellae becomes cataractous. Suppose this one becomes cataractous, but adjacent areas, the black part, that is clear. This is what is called lamellar or zonular. Now it is said that over this lamellar cataract, there can be small spoke-like opacities, and these are what are called riders. Additional, nothing but additional opacities over the cataractous lamellae are called riders. Got it? So these are nothing but additional opacities over the cataractous lamellae, which are called riders. So this is a cue. Now another cue they have asked you is that this lamella occurs due to which vitamin deficiency? We will answer vitamin D deficiency. And second etiology of lamellar is rubella infection. So two etiologies which need mention here. One is rubella infection and second is your vitamin D deficiency. Okay. Now lamellar or zonular involves only the fetal nucleus. Okay, just remember it involves fetal nucleus. Right? So embryonic and fetal is which type of cataract? Infantile. Yeah. So we can say it is one of the most common infantile cataract. It is most common infantile cataract. So that was lamellar zonular. What is the other type of cataract? We are going to see the slides again and quickly revise the types. So don't worry, keep writing. After that is your anterior polar. What do we mean by that? That it is the anterior pole from where it starts. So this is your anterior polar cataract. Now anterior polar cataract generally are associated with persistent pupillary membranes. Okay, persistent pupillary membrane. Right? We next talk about posterior polar. Posterior polar will be associated with remnants of hyaloid tissue. So write down posterior polar cataract can be associated with remnant of hyaloid tissue, which is called Mittendorf dots. We will learn in vitreous chapter as well. Just remember it is associated with Mittendorf dots are nothing but remnant at the back of the lens, These are called Mittendorf dots. So they are remnants of hyaloid tissue. Right? Another very important point about posterior polar you have to know, onion ring appearance. Okay? Onion ring appearance. What is the next type? Next type, number 6. Yeah. So number 6, there could be just peripheral cortical opacities which are called coronary cataract. So what are coronary cataracts? They are peripheral cortical opacities. Peripheral cortical opacities are coronary cataract, right? What else? Sutural. What is sutural cataract? We have learnt about what are sutures. We also learned that on the front surface, they look like a straight Y and on inverted Y in the back surface. Talked about it? So, when the opacities are only along the suture, this becomes your sutural cataract. Okay? So, this is your sutural cataract. Next type, of course, we have to also remember about Wilson's disease causing sunflower cataract, galactosemia causing oil droplet. And lastly, of course, when the whole lens is opaque and the child is born, this is your total congenital cataract. This one is your total congenital cataract. Right? So, these are the types of cataracts. What were the questions? First question, most common type of cataract. Most common type of congenital cataract. If this is your question, your answer will be blue dot. Most common congenital cataract, blue dot. But suppose the question is most common congenital causing marked diminution of vision. Now your answer becomes lamellar. Write down most common congenital causing marked diminution of vision. Then your answer becomes lamellar. And what was the third question we discussed? Vitamin D deficiency. Fourth question we discussed, riders. Right? Yeah. And of course, fifth, they have asked you about onion ring appearance. So these are the questions on types of cataract. And they have asked about your gene responsible for congenital cataract. Okay. Now once we know this, how will this child present to me? So the child is going to present with leukocoria, that is white eye reflex. Leuco is white, coria is pupil. Right? So it is white eye reflex. How will you investigate? Let us understand like this. We divide the investigation as ocular investigation or systemic investigation. So ocular, naturally I have to go for a detailed examination of anterior and posterior segment. So I am going to go for detailed examination and I am going to do a scan, and for naturally I have to calculate the IOL power. I will have to see the axial length also. I will also have to see the posterior segment. So I will do A scan and B scan. So this is apart from your detailed examination. First of all, detailed eye examination is of course mandatory. And after that, we are going to do an A scan or a B scan. Right? And once you have done this, then what next? Systemic white is important. Systemic white is important because we have to find out the cause. So do we do in every case? We will not do if we know that this is a bilateral case with positive family history. Or we will not do if it is a unilateral case because we know the cause. Unilateral, we know what is the cause. So otherwise we have to go for systemic examination, and of course we can divide it as your serum analysis or urine analysis. When you say serum analysis, you will have a general idea of everything. Like you are going to specifically see for the glucose levels, of course. Right? You are going to see your galactokinase levels. You know why, right? You will have to check for torches, titer of torches, right? Titer levels. This should be checked for. So these are few, and apart from that, we also see calcium and phosphorus. So we are all checking for this to find out the systemic cause. This they won't ask you. Now what is interesting and they can ask you is mainly the urine analysis. Let's listen to this more carefully. Now in urine analysis, if you're getting this, what is the diagnosis? If you're getting this, what is the diagnosis? This is what you have to keep in mind. So common sense, if I'm getting a reducing substance on urine analysis, naturally my diagnosis becomes galactosemia. Right? If I am getting amino acids in the urine means we are talking about Lewis syndrome, which is an error of amino acid metabolism. Correct? Okay. And if you are getting sediments, it has to be Fabry's disease. So this you have to keep in mind. Anything else? Yeah, copper, then it is Wilson's disease. Okay. If it is copper in the urine, it is diagnosed as Wilson's disease. And of course, if it is blood in the urine, we all know about Alport syndrome is hemorrhagic familial hemorrhagic nephritis. So blood in the urine means it is going in for, mainly we have to think in terms of Alport syndrome. So just have this idea that how a urine analysis can help me apart from, of course, along with serum analysis for the diagnosis. Okay, so now you have made the diagnosis, why you know, and you can treat in that line and take care of the seismic disease as well. Now, how will you treat the cataract? This is a very, very important exam question. Right? So, they have asked you both the things. They have asked you, first of all, what is the choice of time of and what is the treatment of. So, first they have asked you treatment of choice, and then they have also asked you another Q, ideal time of operating. Right? Both of the things have been asked. Let us try to understand why. So, you already know the SRK formula, we have just read it. So, what is SRK saying? That power is equal to A minus 2.5 L minus 0.9 K. Correct? Now, earlier concept was, okay, why do we want to operate in such a small child who is just born? Let me wait, let the child reach 2 years, and then why 2 years? Because the maximum growth of your eye occurs within 2 years of age. So wait for 2 years, let the of course there will be changes till adolescence, but 2 years the majority of the growth has happened. So wait for 2 years, and then once the child has reached we will calculate the axial length accordingly, and then we are going to calculate the power and put the lens. So when this was followed, it was seen that none of these children had a vision of 6/6. Almost all of them had a vision less than 6/6. So any partial loss of vision is called amblyopia, right? So each child was amblyopic. So why did this happen? And this is the reason we changed our concept and we no more wait for 2 years. So first, why this happened, let's understand. See, what happens when the child is born, have you noticed that he cannot fix at something? The eyes are always wandering. And the reason being, the fovea is still not formed properly. When the light rays fall on the fovea, it acts as a sensory stimulation, and then the fovea is formed, and this is what is called foveal reflex formation. Or we can call it macula maturation, or we also call it fixation reflex. So the three names are for the same phenomenon. Because as the fovea is formed, the eye starts fixing. And this whole takes place by 5 to 6 months. It is complete. This is the critical period. Now the child has cataract. Light rays are not reaching. And if the light rays are not reaching fovea, if I wait till 2 years, I have lost this critical time of 5 to 6 months. Fovea is never formed properly and the vision is never 6/6. Okay, so this is again a very important exam question for you all. Foveal reflex formation occurs by, we answer 5 to 6 months of age. Right? It is 5 to 6 months of age. Got it? And why should you, then when should you operate? Of course, the answer is as soon as feasible or as soon as possible. But it should not be before 1 month. We avoid doing any surgery till 1 month. So, ideal time to operate has to be as soon as feasible, but it should not be before 1 month. Why? Anything before 1 month, if we are operating in such a small child, there is a very high risk of getting inflammatory glaucoma. So what happens? Intense inflammation, it causes inflammation of trabecular meshwork, and when there is inflammation of trabecular meshwork, that is trabeculitis, and trabeculitis causes glaucoma. This happens if we are doing it less than 1 month of age. Therefore, the ideal, of course, even if I am doing after 1 month, when the options are there, it is equivalent to as soon as feasible only, isn't it? But if so, how to manage? If the option says as soon as possible, as soon as feasible, at this, you have to just assess what are the other options written. If there are longer duration, we will mark this. If it is written after 1 month, that will be our best answer, right? So ideally, after 1 month should be our answer. Now, they have also asked you what about unilateral and bilateral. So, to take a midway, we can say if it is unilateral, why? Because if it is a unilateral cataract, amblyopia will be even more difficult to treat. Okay, so because it develops, it is more deeper and difficult to treat. So, for unilateral, it has to be as soon as possible, and if it is a bilateral, we can do it around 6 weeks, that is after 1 month. Now, but when it comes as an MCQ, it may be challenging. So, in either case, actually answer becomes as soon as feasible. So, it all depends what are the options. So, if you have any confusion, you can ask me, right? So, I am never away. You can always ask me, inbox me the questions, and we can always talk, right? Okay, then we talk about once as soon as feasible and I am operating and putting an IUL in a patient who is so small, means the eye is small, means when he grows up, the eye is going to become longer. Think yourself. When this child is growing, the eye has to become longer, isn't it? Do you realize this? Longer the eye means more power, myopic shift. Myopia is more power. So, anything towards more power is called myopic shift. So, if suppose at this age, whatever p-value I calculate, if I am going to put this p-value, it will be according to the axial length at present, whatever the axial length is at present date of this child. But later this axial length is going to grow and can lead to myopic shift, isn't it? So, to take care of that, what do? We follow the Dhanis criteria, which says that if the child is less than 2 years of age, whatever p-value you have calculated, just undercorrect by 20%. Okay, so we undercorrect by 20%. And if the child is 2 to 8 years, of course it's late to operate at this age, but if he is presenting and coming to you in this age, even then we undercorrect by 10%. So, this is what we follow to manage a congenital cataract, right? So, this is the time of the treatment we have discussed. What is the choice of treatment? Of course, it's a phaco. So, here the lens is soft, isn't it? So, softer lens means we are going to go for lens aspiration. Do you remember what we studied? We studied that in a childhood, there is a strong attachment here between the posterior capsule and the anterior hyaloid membrane, and this we learnt as Wiegert's ligament. I hope everyone remembers. Now, why I reminded this? Let's think. See, in a small child, if I am just going to do a simple lens aspiration of phaco, next day the posterior capsule is going to opacify. This much is the inflammation if you operate in a small child. So, when I know this is going to happen, in spite of all the measures I take, the posterior capsule on which the capsular bag and the posterior capsule is going to opacify, what we do, we decide, okay, in the same sitting I will also make a small cut in the posterior capsule. Got it? So, if this is the lens, I am removing the lens and this is the posterior capsule, I have already done anticapsulotomy and done the surgery. I am also making a small opening in the posterior capsule. So, because it is done in the same, so it's not that I am waiting for after cataract to happen. And because I am doing it in the same sitting, I call it primary posterior capsulotomy. Okay. So, this is what is called primary posterior capsulotomy. Okay. So, if we now Think yourself, if I have to do a primary posterior capsulotomy and I am removing the capsule from here, right? This is the capsule and I am making an opening here. Do you realize it is also attached to the anterior hyaloid through Wiegand's ligament? So, when I am cutting the posterior capsule, I will have to also cut a small part of vitreous, right? And do an anterior vitrectomy. Why we have to do this? Because the vitreous is attached to the posterior capsule. Therefore, if I have to cut the posterior capsule, I have to also cut a little, because I don't want to pull the vitreous. It's a very, very big risk of retinal detachment. So now what is the treatment of choice? Your answer will be lens aspiration with primary posterior capsulotomy, right, with anterior vitrectomy, okay. So this is the treatment of choice for congenital cataract, correct? Okay, so one more thing which needs a mention here is congenital rubella syndrome. We haven't discussed this, we will discuss it. Congenital rubella syndrome. I was mentioning to you all that rubella is one of the very important etiology for lamellar cataract. But rubella is not only causing cataract, but there are other ocular features. So let's first understand congenital rubella syndrome. What is the triad? The triad of this syndrome is CHD, cataract, heart defects, deafness. Easy to learn with this mnemonic. It is cataract, heart defects and deafness. Right? Okay. Now, once we know this, they have asked you what type of cataract is most common. So, we are going to answer, it is most common, we will say is, you have to describe it as nuclear pearly cataract. Lamellar also is involving the fetal nucleus only. So, it's a nuclear cataract, but your first answer will be nuclear pearly. It looks white like pearl. Okay. So, nuclear pearly cataract. Then we talk about is what are the other ocular features. Ocular features of rubella. So, can we make a diagram? In my style, we will learn by making a diagram and labeling it. We have to start thinking from outside to in. So, what will happen in the eyeball? All of you, what will happen in the eyeball? So, first thing is microphthalmos. Right? So, what you are getting in rubella is small eye or microphthalmos. When do you call it microphthalmos? Any axial length of less than 21 millimeter or at age of 19 years, axial length of less than 19 millimeter. These are the criteria to define microphthalmos. Okay? Yeah. So, first is microphthalmos. What else I can get? We will learn rubella keratitis. So, we are getting keratitis. Then there can be angle anomaly leading to glaucoma. We have learnt about nuclear pearly cataract. Right? What else? In the retina, pigmentary retinopathy, that is salt and pepper fundus. So, salt and pepper fundus, that is pigmentary retinopathy. What do you get? Is salt and pepper fundus. Okay, so these are the features of rubella, ocular features. Exam question, all of you. Which is the most common ocular feature? You are tempted to answer cataract? Don't answer. Most common we will answer is salt and pepper fundus. Second most common is nuclear pearly cataract. The second most common will be nuclear pearly cataract. Now, what are the differential diagnosis of salt and pepper fundus? Again, a very important thing. Let's learn this also before we end the congenital cataract topic. Salt and pepper fundus. What can be the different causes? Okay, so first is, of course, rubella. Then next is syphilis. Then you have learned with me just now myotonic dystrophy, isn't it? Myotonic dystrophy. A very important topic in retina, retinitis pigmentosa. A variant of this condition is sign pigmento. Sign pigmento. And next we will learn is Leber's amaurosis. Leber's amaurosis. All of you, what is amaurosis? You all should know this. Make a box. Very, very clear. What is amaurosis? What is amblyopia? And what is amaurosis fugax? So, amaurosis means total loss of vision. Right? Amaurosis is total loss of vision. Amblyopia is partial loss. Partial loss of vision. And what is amaurosis fugax? Amaurosis fugax. So this is your transient loss of vision. So whatever vision is gone will come back. So it is transient loss of vision. And if you want to fully describe it, it is transient loss of vision in a curtain-like manner. So in a curtain-like manner. Why do you call it curtain-like manner? Because when the vision goes, the superior field goes first, then the central, then inferior. And when it comes back, it is inferior which comes first, then central, then superior. So curtain is down, curtain is up. Right? Got it? So that was about the causes of salt and pepper fundus. Right? Let's have a look at the slides now. Okay, so what are you looking at? This is what is blue dot cataract. This is your blue dot cataract. As bluish dot. This is what is purulenta. Cataracta purulenta with a powdery appearance. What is this? This is your lamellar or zonular cataract. This is what is lamellar. Can you see? A single lamella is cataractus. We can even see additional opacities. So this is your zonular or lamellar cataract. And can you see these lines? These are riders. So these are riders. Here again, can you see these? These are riders. Right, all of you? So these are just additional spoke-like opacities which are called riders. Okay, so this becomes a polar cataract. So how will I comment? Is it anterior pole or posterior pole? When I see a section of it actually. When I see here, it is even more clearer because it is giving you this onion ring appearance. Can we see the onion ring appearance here? So this is your posterior polar cataract. The onion ring appearance means it's a posterior polar cataract. These are the coronary peripheral corneal, this cortical opacities. This is coronary cataract. And what is this? Sutural, along the sutures. Can we see that Y? So it's a sutural cataract. Okay, again this is sutural. It has involved all the rest part of the lens as well, right? This becomes our total congenital cataract. This is a total cataract. Okay, now we are looking at rubella. So this is the diffuse pigmentary retinopathy. What is pigmentary retinopathy? I said it looks like salt and pepper means all the pigment is all around as if it is a pepper, right? So if I ask you what is salt and pepper fundus, all of you please listen. What is salt and pepper fundus? Do you realize in case of rubella also, it is of course salt and pepper fundus is a morphological description for the pigmentary disturbance in the fundus. But why is that happening? It is happening due to diffuse chorioretinitis, inflammation of choroid and retina, especially in case of rubella and syphilis. Okay, so for rubella syphilis, this is mainly a itis diffuse chorioretinitis. So here again, can you see this? You appreciate these are the pigmentary dot. So this is what is salt and pepper fundus seen in. So this is what is pigmentary retinopathy. Okay, so what are you looking at now? I can see an inferior subluxation of lens. So our next and the last topic on this chapter is subluxation. So I can see here the inferior subluxation of the lens. And what is this left is called golden crescent. This fundus that you can see, this becomes our golden crescent, which is typical sign indicating subluxation. Okay. In this case, this is upwards. Subluxation is upwards. Okay, so let's give the next heading, subluxation of lens. We all know the lens is situated in the patellar fossa, right? So whenever part of the lens is still in the patellar fossa, still visible through the pupillary area, and part is not, that is what is called subluxation. So subluxation is nothing but partial dislocation, right? It is a partial dislocation where part of the lens is still in the patellar fossa. Part of lens is in the patellar fossa. Correct? Okay. Now, what can be the causes? We just saw the slide how it looks like. So, what can be the etiology? We can divide it as acquired or it can be a genetic cause, hereditary or genetic. Now, when you talk about the acquired causes, of course, first thing that should come to your mind is trauma. So, we are saying that first cause is trauma. Trauma is one of the most common cause of subluxation. This is your exam question. Overall, most common cause, it is trauma. Then, what can be the other causes? Of course, think yourself, whenever there is a large enlargement of the eyeball, the support of suspensory ligament is gone and there can be subluxation. So, this can happen in ophthalmos, where there is enlargement of the eyeball, or it can also happen in high myopia, right? Correct? Where else it can happen? Again, think yourself, support of zonules, they can be lost in pseudo-exfoliation syndrome. We are going to read this in our glaucoma chapter, pseudo-exfoliation syndrome. And chronic uveitis. Next is chronic uveitis. So these are some, and of course, did we not learn about the most common complication of hypermature nuclear sclerotic is subluxation? So we can note down hypermature nuclear sclerotic cataract, right? So these are all the acquired causes of subluxation. Okay, so when this subluxation is genetic, hereditary, we call it ectopia lentis. Okay, so the hereditary cause, this is what is ectopia lentis. And what can be the causes? Now this ectopia lentis is divided into three. First is your simple ectopia lentis, which means there is only one feature and that is displacement of the lens, right? Or familial ectopia lentis. So this simple includes your familial ectopia lentis and it is mainly autosomal dominant. Now second is again ectopia lentis et pupillae. Et pupillae means pupil is also displaced this time, and as a rule it is always opposite to the direction of lens displacement. If lens is displaced downward, pupil is displaced upwards. Okay, so this is ectopia lentis et pupillae. And third is ectopia lentis, which can be associated with systemic diseases. Right? So systemic disease, what are the diseases? This one is very important and asked in the exam. We will make a double Q here and note down what are the diseases associated with ectopia lentis. So all of you, main important Marfan syndrome, right? Then next we will learn homocystinuria, then Weil-Marchesi or Marchesani, both are same, Weil-Marchesani or Marchesi, Ehlers-Danlos, and few more we will just write after this. If you want to write, okay, write down. Few other after Ehlers-Danlos, the next cause could be sulfite oxidase deficiency, then hyperlysinemia. These were also your options in your exam question. All are causes of subluxation except, so you should know it. And one more that you can learn is Stickler syndrome. So this is also a disorder of collagen production. Okay, so where you can get a subluxation of lens. I think I mentioned it earlier also that the most common ocular feature of Stickler is retinal detachment. You have to keep this in mind. I just want you to learn this much. It's a disease where there is a defective collagen production. Okay, and most common ocular feature, retinal detachment. We also get your subluxation. Okay, so that was to complete the list. We come back to more details are needed in these. Very important. So the next thing they started asking was which direction ectopia lentis occurs. So this is my age-old, very famous method, how to remember the directions. We make M of Marfans. And over the head of the Marfan, we will put an arrow. So what direction is this? It is supero and away from the nose is temporal. So it is a superotemporal ectopia lentis. Okay, so this is superotemporal ectopia lentis. This is what you get in Marfan's. And then in the same diagram, we can make dotted line and put an arrow like this. So just the opposite, down, infero and nasal, not temporal but nasal is H, right here H, homocystinuria. Okay, it is infero-nasal, correct? Then we talk about, and there was one question where inferior and nasal both are given separately. Definitely we will first mark inferior. And they're coming to Weil-Marchesi, it is inferior subluxation. And along with that, what you get is small spherical lens, which is called microspherophakia. Small and spherical lenses, microspherophakia. Right? Ehlers-Danlos, no direction mentioned. We simply learn ectopia lentis. And another very important feature here is blue sclera. This is also a Q. Okay, so blue sclera. What is blue sclera? Sclera is blue in color? No. So it's a very thin sclera so that the underlying uveal tissue is visible. That is called blue sclera. We'll talk about its causes in sclera chapter. As of now, we will just learn this as blue sclera. Right? Okay. So these were the important points to remember. So, and you should also have an idea. If you talk about, you should also have an idea that if you talk about Marfan's, the patient is tall, hands are long, fingers are not long, arachnodactyly, right? And just opposite is the patient of Weil-Marchesi who is short-statured with stubby fingers. Okay, will you remember that? So, the patient of Weil-Marchesi has short stature and stubby fingers. Now, a little bit more about Marfan's is needed. Let's talk about Marfan's. So, when you talk about, next is ocular features of Marfan's. When I am talking about ocular feature, as usual, we will make a diagram and label it. What did we learn? Patient is tall, hands are long, fingers are long. So, learn with me, even eye is long. So, the first thing, eyeball, we will learn axial myopia. Right? Eye is long means axial myopia. Secondly, naturally there will be stretching of the cornea if the eyeball is stretching. So, what you get here is megalocornea. And also the curvature is less, which is called cornea plana. So these are the two findings in the cornea that we get. What else I will get? Of course, we get angle, we get ectopia lentis, which is superotemporal. Let's learn like this. We can also get hypoplasia of dilator pupillae. Okay, dilator pupillae, hypoplasia of dilator pupillae is the muscle which dilates. That means there is hypoplasia. It will not dilate much. Okay, and when the axial length is long, can you think of if there is excessive axial length? What are the changes in the retina? We will learn it in the retina chapter also, that we can get lattice degeneration in the retina. We can get lattice degeneration. And what else we can get is rhegmatogenous retinal detachment. Rhegmatogenous retinal detachment. We'll talk about types of rhegma means break in the retina. Okay. So rhegmatogenous retinal detachment. These are the findings of Marfan's. Now they've asked you which is the most common finding, which is the most prominent finding. I'm not sure they will ask you again or not, but that time the question was mentioned and the prominent was written in capital letters. This is what I was told. So most prominent, which can be obvious, you don't need a slit lamp also, is megalocornea. So whenever we answer, we can answer like this. Most prominent, okay, let's choose megalocornea. But most common is ectopia lentis. Right? So most common is ectopia lentis. And what is the direction we learned? This is superotemporal. And okay, so this was about important information regarding your subluxation that you should know. Now talking about how will you manage it. So if I have to manage it conservatively, if there is a problem in the vision, right? So what we do, we are going to give a spectacle correction either from phakic or aphakic part. You just saw the golden crescent, that is a aphakic part. And or it could be a phakic part where the lens is there. So whichever is larger, I will choose and I'll give a spectacle prescription. Okay. So first thing is if I want to manage, I'll go for a spectacle, write down spectacle correction from phakic area or aphakic area. Whichever is more. Right? But if this is not comfortable, it is not working, so we have to go for surgery. Now surgery, it will depend. If the subluxation is less than 9 clock hours or it is more than, right? 9 or 9 clock hours, or is it more than 9 clock hours? If it is more than 9 clock hours, I have no other option. I have to do your surgery and remove it. That is ICC. If it is a cataractus lens, definitely then the whole lens is removed. Right? So you have to go for removing the lens. But if it is less, I can still manage to keep it there. It may not be even cataractus. So how do you do that? So in less than equal to either 9 or less than 9 clock hours are involved, we can go for capsular tension rings. Okay, I'll just show you. This is a capsular tension ring. Or you can say capsular ring segments are there. CRS, this is capsular ring segments. So this will help to stabilize the capsular bag and support the bag for this. For the area where there is no support from the suspensory ligament. Got it? So it looks like something, the ring looks like, please draw it with me, I'll show you. Like this. Or it could be with one eyelet. If it is with one eyelet, it will be like this, an extra eyelet. So this is with one eyelet. And a segment means it is just one segment here. Right? So let's have a look. So this is your ring, capsular tension ring, right? And can you see this? This is with an eyelet. One eyelet is there. This is a segment. The segment with an eyelet. And look at this one. This is how we're injecting the capsular tension ring. To expand the bag. Inside you are injecting to expand. And to support the bag mainly. Not expand exactly, support the bag. Here we are doing it in pseudo-exfoliation syndrome. PXF is pseudo-exfoliation syndrome. Right? So when you're drawing a segment, you have to draw this also. No? Then only it's a segment. Just correct this drawing like this. This one is with an eyelet. Okay, so either it is whole ring or it is a segment. Okay, so that was the management of subluxation. And this is all regarding your disease of lens. A very, very important topic, definitely. Majority of the OPD patients are patients of cataract, isn't it? So, very important topic for you all. Lot of questions you must have realized and written all the Qs and double Qs. Please revise it nicely. Okay, so thank you so much. Stay blessed. Keep smiling.